Okay, well, good evening, everyone. Hello from Minneapolis. Super excited today to host this event as the Medical Industry Leadership Institute, where we have a fantastic panel of speakers who's going to share their insights and observations about the Minnesota Council of Health Plans and the nonprofit health plans in Minnesota. My name is Pınar Karacamandic. I'm a professor at the Carlson School of Management. I'm a health economist, and I'm the academic director of the Medical Industry Leadership Institute. And as a researcher myself who's fascinated about the health insurance marketplace, it's such an honor to have our speakers today. So I'll quickly introduce our speakers, and then we will have a casual conversation about the industry, the macro trends. I don't know, I'll find some very interesting questions to ask them. Okay, so our first speaker is Lucas Nesi, who is the president and the chief executive officer of the Minnesota Council of Health Plans. And Lucas guides the council's members towards consensus, and he is the face and voice of Minnesota's nonprofit health insurance companies. He joined the council as its president and CEO in November of 2019, where he works with all of the member health plans and stakeholders to pursue high quality and affordable health services for Minnesotans. Prior to his role, Lucas was the Health Policy and Grassroots Director for the Minnesota Business Partnership, and also previously served for 9 years in various roles at the Minnesota State Senate. He's on the board of Minnesota Community Measurement and was named by Minnesota Physician as one of the 100 most influential healthcare leaders in the state. Lucas earned his bachelor's degree in political science from Gustavus Adolphus College and his Juris Doctor from William Mitchell College of Law. Thank you so much, Lucas, for joining us today.
Thanks, Pınar.
Our second speaker panelist is Andrea Walsh, who is the president and chief executive officer for Minnesota-based HealthPartners, the largest consumer-governed nonprofit healthcare organization in the nation. Andrea leads a team of more than 26,000 people focused on the mission of improving health and well-being in partnership with patients, members, and the community. Prior to her appointment as president and CEO in 2017, Andrea was part of the HealthPartners senior executive team for more than 20 years, including serving as executive vice president and chief marketing officer for nearly 15 years, and as senior vice president and corporate counsel. Prior to joining HealthPartners, Andrea practiced law and was an assistant commissioner at the Minnesota Department of Health. She's a graduate of the University of Minnesota Law School, go Gophers, and the University of Kansas. And thank you so much, Andrea, for being here with us.
Thank you. It's great to be here.
And our third speaker is John Naylor, who is the president and chief executive officer of Medica. John has more than 30 years of industry experience, including more than 10 years with Medica as senior vice president, commercial markets, prior to being named the president and CEO of Medica in 2017. He's a member of the board of directors of Medica Holding Company, which oversees Medica's family of businesses and the Medica Foundation. Prior to joining Medica, John spent more than 20 years at Willis Towers Watson, formerly Towers Perrin, as the market leader for the Towers Perrin Minneapolis office and managing director for the U.S. Central Region. He currently serves on the board of Greater MSP and is a member of the Itasca project. He also serves on the board of the Minnesota Council of Health Plans. Thank you, John, for joining us as well.
Thanks, Pınar.
And so I think we can start kicking off our event learning more about the Minnesota Council of Health Plans. I have to say, as I discovered Minnesota Council of Health Plans as a researcher, I was able to observe the amount of connections and the resources you have and the work that you do. So it would be very great, Lucas, if you could tell us a little bit about the council. Maybe you could touch on the history of the council and the importance of nonprofit health plans in Minnesota and the impact that they are making to shape healthcare in Minnesota.
Sure, thanks, Pınar, and thanks so much for the opportunity to tell you and everyone that joined today a little bit more about the council and its history, which really started as an idea early in the 1980s when a group of Minnesota's nonprofit leaders decided that even though as individual organizations they were serving Minnesotans well, they could actually do much better in areas of common concern if they worked together, that being providing broad access to high quality care at a lower cost. And that informal group really became the Minnesota Council of Health Plans you see today, and essentially continues to operate under that same mission as well, nearly 40 years later. Our nonprofit health plan members, which obviously include Medica and HealthPartners, also includes Blue Cross Blue Shield of Minnesota, ViewCare, Sanford Health Plan of Minnesota, and Hennepin Health, which collectively have grown to provide coverage for more than 4.5 million Minnesotans and nearly $30 billion in medical bills they receive each year. And that's 30 billion with a B, which is really important because, if there's anything I can leave this group with today is that health plans do so much more than just pay claims. They support overall wellness in the community as well. And importantly, while we do successfully work with the for-profit organizations on a number of issues, our members' nonprofit status means they're mission-based organizations. You'll find they take that very seriously in their support of their members in the community, whether that's supporting a local food bank or addressing homelessness. You'll hear more on that passion from Andrea and John later this evening.
Thank you so much, Lucas. Well, maybe I'll ask Andrea sort of a related question about maybe what aspects of the nonprofit health plans make them unique in Minnesota? Are there certain examples you can share?
Sure. Thanks for that question. And I think that the Minnesota market has benefited greatly by virtue of the fact that both our health plans and our healthcare systems are largely nonprofit. And I think nonprofits by their very nature are community-centric, focused on serving and benefiting the communities that we reside in, the communities that our people live and work in. We exist not for shareholder benefit, but truly for community benefit. And I think you see that show up in the value that we bring to communities. We're able to take a long-term perspective on the health of the community. And I think here in the Minnesota market, just to call out a few things that have really been key examples, is our focus on access to high quality, affordable healthcare led the health plans in this marketplace to create Minnesota Community Measurement. And we did that in partnership with the other trade associations in the community. And the idea was to create a common yardstick by which we would measure clinical quality and a common yardstick to measure value or affordability of care. And we agreed as an industry that we want to compete on that yardstick, but we don't want to compete over who's got a better yardstick. And so I think that again goes to the value that a nonprofit perspective brings to the community, and the partnership that HealthPartners, Medica, Blue Cross, ViewCare, Preferred One have brought to the community in the past. And I think the community has benefited, and we've got several examples of community benefit efforts that are underway as we move forward, and we can talk more about that as the hour moves on.
No, that's such a fascinating example, the Minnesota Community Measurement, of course, from a research perspective as well, such a useful collection of databases with which we can actually make measurements. And also I love the way how you described it. It's fierce competition, but competition on an agreed upon standard set of metrics, which is really great. Thank you. John, maybe I'll move the conversation a little bit towards more of the macro trends and maybe industry trends, and maybe if you could address some of the emerging trends that you see in the macroeconomy overall and healthcare industry, of course, and how have the Minnesota nonprofit plans, how have they been responding to these trends? And again, as both Andrea and Lucas also already mentioned, with that goal to keep affordable, high quality and low cost healthcare for all Minnesotans.
Sure, Pinar, and I'll probably connect this to what Andrea said in her response, because I think if you look at this market, the nonprofit health plans and the nonprofit healthcare providers have worked for decades together. And there's no better example than with COVID and what's happened, where we came together and worked together with the state. But at a macro level, it's really the affordability of healthcare that's a critical issue and continues to be. The nonprofit health plans are focused, as Andrea and Lucas said, on the community. We are focused on the health of our community, and we are all doing different things. So I think from a Medica perspective, one of the things that we've done is working with our nonprofit providers. We created special value-based arrangements that we call ACOs. So we're working together to focus on better outcomes and lower cost. And at the center of all that is the member or the patient. And we're really focused on data and analytics to look at patterns of care, best practices, as well as looking at the data and analytics on preventive basis and predictive basis, so that we can focus on providing better care at a lower cost for our partners. The other thing that we've done is pull these ACOs together, because we recognize there's value one-on-one, but the collective value of bringing folks together. So annually we have a summit, and we have 24 of these ACOs now throughout the heartland. And we share best practices and focus really on the community and how do we improve better health. So that's just one example from a Medica perspective.
Yeah, and Andrea, did you want to share some examples from your perspective?
Sure. I think there's a few examples, and actually an example of collaboration between health plans. We've been engaged. HealthPartners has convened a group of providers. Obviously, one of the things when we all are focused on community health that really matters is what happens outside of the healthcare industry. So when you look at what truly impacts mortality and morbidity, only about 20% of mortality and morbidity relates to access to healthcare. Clearly something very important. But when you look at what's oftentimes called the social determinants of health, 40% relates to social determinants. Do you have access to a good job? Do you have childcare? Do you have an education? Do you have housing? Are you living in an environment where it's walkable, where you can get the steps you need to stay healthy? What about the healthy habits that you may or may not have? Do you live in a food desert, or do you live in a place where you have access to healthy foods? So one of the areas of focus HealthPartners has had relates to maternal and infant health. And the recognition that your birth outcome varies based on your zip code. And that shouldn't be the case. And when we look at health long-term, the biggest predictor of health long-term is a high school diploma. So at HealthPartners, we've really been focused on 0 to 3. What can we do to make sure every child in our community has a healthy start? And we have convened a broad coalition of stakeholders, including the healthcare industry, the business community, the nonprofit sector, to really look at how do we make little moments count? How do we begin a social movement so that every parent, every child, every family, every community organization that knows that what happens in that first 3 years of life either sets you up to be a lifelong learner or sets you up to have challenges that will emerge over time. And I think it's a good example of how nonprofits focus in and with community in partnership with others. And I'm excited about the momentum that's built around Little Moments Count. And I think long-term, it will have a long-term impact on health that couldn't be measured if you were looking at quarterly reviews or quarterly returns. It's really long-term investments. And that's fundamentally what nonprofit health systems are all about.
No, that's an excellent point. And, all these examples you brought up, Andrea, about social determinants of health and social well-being, just preventive care, all of these, as an economist, I see them all as investments that need to be done but with long-term return. Mm-hmm. And that idea about collaboration and the commitment to long-term, when we think about insurance contracts, usually from year to year, but that environment that can support that long-term collaboration for the sustainability of such efforts is super important, and definitely something we've been working and creating some ideas at the university as well. So definitely want to share those. Lucas, both Andrea and what John shared, is it sort of similar across the other health plan members that you are hearing about in terms of the trends and their work towards healthcare being affordable, keeping it high quality and low cost?
Yeah, absolutely, Pinar. And one thing I'll kind of add is that the national debate recently, and dating back several years, has been really around subsidies. And I think, kind of to John's point, subsidies are extremely important for affordability, but we don't want to lose focus on the underlying cost of care, because healthcare is just simply expensive. And one of the ways we're trying to get a paradigm shift going on is once these debates around subsidies get settled, how can we focus on that? And at the state level here, we're working with the Minnesota Chamber of Commerce on what we're calling the high value care initiative, which ultimately focuses on eliminating low value care, which is essentially unneeded tests, services, and pharmaceuticals. You see studies out there that upwards of 25% of care is completely unnecessary and can be avoidable. And if you think about the amount of money that I mentioned in the introduction, that is a very substantial amount of money that can be reallocated to support wellness in a more optimal way.
Oh, it's very interesting too. Again, I can't help but make the research connections, because something we have also been working on is, we call it de-adoption. It's sort of like the adoption, like it's really important, as the clinical evidence shows, that treatments are effective, that we adopt them in clinical practice, but it's equally as important, as the evidence shows, that treatments are unsafe or ineffective, that they are de-adopted, and they're not the mirror image of each other, which is really, really interesting to study. But
hey, Pinar, it's John. Can I just jump in with one?
Yes, please.
I know that you've got the three of us on here, but as we say, there's more nonprofit health plans with UCare, Blue Cross, and Hennepin Health, and I just want to acknowledge that we all come together, and through the council, we have initiatives to try and address the health disparities that are out there. And we have all worked collaboratively to work with the state and the care systems to address some of the disparities that are out there. Andrea mentioned a few, but I just want to acknowledge that it's more than just the three of us that are making a difference out there.
Yeah, the other thing I would just add on in terms of value is the focus not only on making sure health care is affordable, but the focus that we have on prevention and the partnerships that we have built to make sure that people get in for preventive services that help us manage longer term costs and identify illness and disease early.
No, absolutely. Well, thank you. I would like to send a note to our audience. If you have questions, please put your questions in the Q&A or the chat, and I'll try to monitor as much as possible. If I can blend them in our conversation, I will, but otherwise I'll try to, leave 10-15 minutes at the end so we can answer some of those questions as well. Okay, so I know, John, you alluded to this thing in my head a little bit before, but of course, the use of big data and different types of healthcare data becoming so prevalent over the last, really over the last 5 to 6 years, how I would say from my perspective, we have seen a lot of new data coming in, and different kinds of data coming in, and different algorithms, and being able to use big data in innovative ways. I just wanted to get a sense from both John and Andrea, both of you, as to how your organization has been using the big data, however you may want to define big data, and R&D and other types of innovations to drive decision-making towards your goals.
Sure, I'm happy to jump in on that. I think I'm probably talking to the master on research and big data with Pinar there, but I'll give it my best effort. For those of you that know me, I'm an actuary, and you need data to make informed decisions. And the number of folks that we've hired with data or analytics in their name over the last year has been pretty incredible. And it's really fun to watch big data come together, because it's integrating data, as you alluded to, from multiple sources to identify opportunities quickly and to really focus on how can we make an impact with that data. And the data is being focused, I'd say, on two sides. One, macro or population health issues, and second being individual issues and individual healthcare. So on a macro basis, we're doing a lot of analysis of geographic or provider basis identification. So from a geographic zip code or area, or for a certain provider, are there patterns in care that are sticking out? Are there deviations from expected claims? And then at the same time, from an individual basis, we're looking for indicators of potential future health issues or lack of adherence to current clinical care recommendations. And the other thing I'll just add is back to the increasing array of data sources. There's a lot more demographic data that we're using to do social determinants of health to really target specific individuals or populations for programs, for outreach, and try and engage them in health. So those are some examples of how we're using big data. And with that, I'll turn it over to Andrea.
Sure, maybe just to build on John's point about the importance of using big data for personalization. Healthcare consumers want to know that the health system they work with knows them, knows their health status, and is able to meet them where they're at in terms of range of services and options available. So an example of some of the work that we've been doing at HealthPartners relates to improving preventive screening rates for our members across the board, with a specific eye around health equity. As we look at our data, we know and understand, for instance, that we have a proportion of the population, men over 50, Black men and Indigenous men, who are our health plan members who are overdue for a colonoscopy. And despite all of our best efforts and communication with and through our clinicians, both our own care system clinicians as well as our network clinicians, you know, a colonoscopy is nothing anybody looks forward to. And if you happen to be in a community where colonoscopies and that kind of preventive care has not been something that has been part of how you interact with the health system, there's just no way to get folks to come in for that preventive screening. We have used the FIT test, which is essentially a mail home kit, a stool sample kit you can mail to somebody's home, and in the privacy of your home, complete the test, send it back to us. And what we found by using big data and personalization is we're able to target how we communicate with members and the approaches that we use to help drive better preventive service outreach efforts and frankly, to raise our quality scores and make sure that our members are getting access and using the preventive benefits that are an important part of having health plan coverage.
No, thank you. You both mentioned the outreach, and using the data towards outreach. Actually, there's a very interesting question that came in, and maybe one of you could address. How do you engage with local community service organizations to help address health outcomes? So in that way, the outreach piece, what are some ways you do that?
So maybe a quick example, I can start vaccine equity work. As a health plan, when we look at both our commercial and our Medicaid populations, and how do we reach into and across all of the communities that we serve, we have worked with community organizations to bring vaccine to community and to bring, frankly, our team from community into community to talk about why is it important to get a COVID vaccine? What is the science behind it, and why as an individual clinician of color or a nurse or a health plan employee, why are you choosing to get vaccinated? And I think, co-design with community has been a really important part of our equity work. The other thing that's been really important is making sure that the work is getting done outside of the walls of our institutions.
Yeah, I'll just add there's two areas that I say we connect with the community. One is we do have community coordinators that focus on a county basis of working with the various counties on especially the needy population or those that are underserved. So we actually have people in the field coordinating. The other is through the Medica Foundation. It's a way we leverage our resources. So we have a foundation that gives grants every year to organizations throughout the state to help them do outreach. And so those are two ways we directly, and then we leverage our resources for others to help them help our community.
No, thank you so much. Thank you so much for that. What I wanted to ask a little bit more, as we're speaking about the communities and the health plans' work with the communities more directly, the CDC has recently identified racism as a serious public health threat in the US. So could you please share a little bit about how the industry is tackling health equity and social justice issues and your work with the communities more directly in addressing some of these?
Yeah, and I can take that one, Pinar, and building on what Andrea was talking about, the successful partnership that we've seen in this vaccine equity effort also involves the state as well. It's a highly coordinated effort that we've seen real results in as well. What we did there was identify socially vulnerable zip codes, and try unique outreach efforts in different areas to find the best way forward. And there's going to be a lot of lessons learned that we're able to carry forward and hopefully address some equities in the longer term as well. But Minnesota's health plans have really been trying to work hard on these inequities over the last several years, but everyone is also recognizing that more needs to be done, of course. So what we're doing is trying to get the community and the state as a whole to come together to make that meaningful change. There's a lot of good work going on, but how can we work together and take it to the next level is really what everyone's talking about. And one of those is what we call taking our services to where people live. And it's partnering with those community organizations you're talking about to arrange transportation, medical appointments, mobile clinics in some of these underserved communities, and even using telehealth in a unique way to reach people who lack access to care. And there's also a lot of talk about developing more culturally appropriate services, having diverse staff and leaders in organizations, diverse providers. We do this by providing interpreters, languages, materials in other languages, and just strategies in general to identify providers of color, because research has shown that a diverse set of clinicians play an important role in outcomes. And finally, bringing a renewed focus to this. Again, this has been a long-term goal, and we're all trying to make more progress together. So here at the council, we've created a new health equity committee over the last year, which brings all the chief medical officers of our members together to find unique and innovative ways to finally make progress in closing these disparities. It's just everyone recognizes is too prevalent in Minnesota.
Oh, thank you. One question that's related to the work with the communities and how the health plans are serving the community. Of course, our talk is about the nonprofit health plans in Minnesota. So the question is asking about beyond the community health focus, what other differences might one see when comparing nonprofit to for-profit organizations?
Maybe an obvious one is profit and margin expectations. As a nonprofit, our focus is on making healthcare more affordable. It's on a mission dividend, if you will. So we target a margin which we need to be able to reinvest in our services to support community health, but a margin of 2 to 3%. I think that is in pretty stark contrast to what a for-profit health plan would need to have to be able to be successful long-term. And I think from a Minnesota Council of Health Plan standpoint and as nonprofit plans, our belief is healthcare is unaffordable, and we need to do everything we can to make it more affordable and to keep margins in check as part of that.
I'll just add a little bit about the culture. I have, consulted for 25 years across the entire country, and then coming here to a nonprofit organization, the culture and mission that we have, and it's true for all of my peers here, it's really about serving our community. Everyone here gets involved in volunteering. We constantly have events going on within the company to give back to our community. And you can feel the passion and empathy for our neighbors in doing something different for them. It is real. So I don't know how much more to describe that, but it is really the mission. One of the things we do is before all employee meetings, board meetings, we start with mission moments. We give an example of where we've changed somebody's life because so many of us are behind the scenes, whether it's in finance or IT. You don't get to see what we're doing on the front lines. And so we share that to continue to drive that home and that focus of we're making a difference in people's lives. A lot of time when they're struggling at their worst time, they're looking for resources, help, and care. And the nonprofit health plans and all health plans are there, but we truly live our mission with every interaction.
No, thank you. There is one other question. I will maybe add a little bit of my twist to that too. The question is asking more about clinical areas in specifically, but I think I'll expand that a little bit more and say clinical and other areas and other community investments and other work. What are some areas that, clinical and other, that you're seeing as opportunities for both adoption and de-adoption that are being underinvested right now? I know, Andrea, you mentioned the way you see it as if healthcare is unaffordable and that's where more is needed. Are there other sort of areas you can pinpoint as there's too little investment that needs to be upped, vice versa?
Yeah, I think one of the really important roles that a nonprofit health plan plays is in helping members navigate and get the best value out of their health plan coverage and out of their network, and helping guide to appropriate resources. So for instance, we know people who don't have a primary care provider may choose the emergency department as the site of service for what is really primary care. And it puts a hospital emergency department in a difficult situation because you need to take everybody coming through your doors. So I think the partnership between health plans and networks to help guide people to appropriate sites of service is some important work that has an impact both on clinical quality as well as on affordability.
Thank you. Let's see, I'm getting more questions. I'm gonna look at them in a bit, but maybe I will, for right now, I want to shift a little bit to, because we have a lot of students and other working professionals at this presentation. I want to get a little bit about the organizational structure and the employment opportunities that may exist with the nonprofit health plans. So maybe if all three of you maybe could describe the growth and employment outlook in the industry, and do you see certain trends in employment? I see Lucas is unmuting, or okay, go ahead, John. Yes.
I'm happy to help because there are opportunities in a lot of areas. Clearly, we have the same kind of roles as any business, whether it's IT, finance, legal, but there are some unique roles within our group around compliance or actuarial or health management. But the one area, as we talked about earlier, that is a huge need is data and analytics. So thinking about this audience in terms of career opportunities, I think data science, I think there's a lot in the IT space. More and more of our needs are in the digital space, whether that's communicating with individuals and using different technologies of outreach to big data, and how do we be more efficient in what we do. We all are struggling with operations and entry-level staff, just like most companies across the country right now. So I don't know what the answer is and where all these people went, but there are huge needs we have at entry level across the organization in a lot of different areas. And then obviously on the clinical side, I will do a shout out to Andrea's folks in the hospital on the front lines during COVID and what they've done, the empathy and compassion. But we know a lot of people are getting out of the profession. A lot of people are looking at what's happened in COVID and leaving the market. And we need clinicians and people that want to be part of the health care space. So we all have those needs. So Andrea, you want to add onto that?
Well, I think what you said is well said in terms of the increasing opportunity in the data sciences field, the opportunities that exist across administrative areas, and then the opportunities for those for clinical roles clearly, and the opportunities for blended roles. I think when you look into nonprofit health plans from a career standpoint, what you see are many individuals who began in one part of an organization and over the course of their career had the opportunity to migrate into other areas and test and try new things. And so I think from a career standpoint, that health plans are a great place for individuals to be able to begin their careers and then stay through career.
What should I say to my undergraduate students as they're building their skill sets as to some of the key things they should be doing as they prepare a career in healthcare, not just in the health plans, but from your health plan perspective? Good career advice for my undergraduates.
Well, I think in general, the best career advice is to figure out where your passions lie. And to figure out, you know, what will jazz you when you get out of bed in the morning and begin your workday wherever your workday may be. Because I think if you find purpose and meaning in your work, you will be happy, the happiest. If it is just a job, it's a long career.
Yeah, that's so true. That's kind of where I was going to say, life is a journey, and you're going to learn for every interaction of something you like or you don't like. And if you have an opportunity you don't like, get out. There's, like you said, Andrea, there's plenty of opportunities out there. So, and I'd say try different things, explore, stretch yourself. And I still think even in this virtual world, and we can talk about that in a bit, but people skills are still important. You still work in a team in a collaborative environment, even though you're working virtually in many cases these days. So continue to get to know people. Your network is going to serve you well throughout your career.
And our MBA students who may have already committed to the industry and wanting to work in healthcare space, what are some skill sets as you see, of course, the people skills, but what are some other kinds of skill sets as you see the industry growth and the trends that they should be looking for adding in their toolkit?
Oh, I think that the MBAs, I mean, obviously the intelligent individuals think about the question ahead of the question. I mean, be thinking about next steps. Why is somebody asking me that question? What is the real issue, the underlying thing? Don't just answer the question in front of you, but probe and think broader. And if you're asked to come to the table with an answer to a question, think about what drove that question. What was the question before that? So again, I think the more we can get people thinking about strategic questions and thinking out of the box, and that's where the different experiences come into play. If I have somebody that's been in a certain role for 10 years, somebody that's done some other stuff for 3 years, 3 years, and 3 years, and is broad, that candidate might be more interesting because they're bringing diversity of thought to the role.
I think the other thing that is key is the ability to play well with others. Healthcare, health plan work is team sport. And oftentimes, you know, as an undergrad or even in MBA, so much of where you focus is on individual contribution. And so figuring out how you bring what you've got to the table in a way that shares and creates abundance and a better work product and collective wisdom, I think long-term sets people up for greater career success and doing well in what you're currently doing.
Right. And so as you give this advice, and could you maybe describe the organizational structure of your company, like in terms of different divisions and operations, and what types of jobs and careers? And Andrea, particularly for you, you have a, you know, how do you leverage the sort of the integration structure in your organization?
Sure. So I can start, but our structure, obviously, as an integrated care and financing organization, our capabilities include care delivery, full continuum of care from primary care through specialty to hospital, and across virtually all healthcare systems, or healthcare settings, so hospital, ambulatory, surgery centers, specialty centers, primary care, and virtual. So care delivery, a key capability and part of our organizational structure in a division. Our health plan, providing health coverage, both fully insured and self-insured, is part of our core structure. And then our administrative services, which really cut across both healthcare and plan and are structured in such a way to provide services for both our health plan and our care delivery organization. We also have a research and education institute that fuels growth and innovation and advanced learning for both our care delivery system as well as our health plan. So we're structured in a way like a lot of health systems where we have matrix reporting and accountabilities that cut across specific areas, whether it's health plan or care delivery.
Thank you.
Would you like me to address that too, Pinar?
Sure, yeah.
Obviously, very similar. I think we have a network. We have probably 6 key teams underneath me. One is network and provider relations. So really that glue and connectivity with the care system side. We have a clinical team, which has all of our physicians, our nurses, our care coordinators, and our pharmacy teams. We have our finance team, which has actuarial team. We have legal and compliance. We have HR, and then markets. So I think that's 7. Sorry, I said 6, 7. Markets, which is all of the segment folks. So how do we go to market, whether it's commercial, individual, all the account management and product folks that support that. And under ops is also IT. So.
Great, thank you. So, and then I had one other like several questions I got, and I still want to encourage the audience to send in questions. They kind of relate to this idea around the different segments in the markets. You know, when I asked one of my earlier questions about some of the emerging trends in the economy and how the health plans are, nonprofit health plans are responding to these trends, perhaps one thing we can kind of go back to that question and go a little bit more in depth about the effects and how do we address the effects on stakeholders in different market segments like commercial, Medicaid, and Medicare. Because two of the questions, I want to kind of read them to you, are getting at that idea around any plans, like so one of the questions is, any plans to develop new products that can address the gap for individuals who are not covered by employer sponsored insurance or Medicare, Medicaid. So that's sort of getting at that idea of there are these very unique segments in the market and how are you addressing them differently. And then the other one is saying that it seems that employer-sponsored insurance creates a condition of employment in order to have reliable insurance. And that said, what have you done to change the flawed healthcare industry as it stands? Just reading the comments that are coming in. So if you could give a little bit of your perspective on those different segments and how you're working on those different segments.
Sure, maybe
should we talk a little bit about the Affordable Care Act? Go ahead, Lucas.
Yeah, Andrea, I was going to jump in since I brought up the subsidies earlier, because it's something that is continuously in the news, but remarkably, that's only about 160,000 people in the Minnesota market. So it's the relative, I think it's the smallest market piece in Minnesota, and we spend the most amount of our time talking about that piece of the market. Then you have the small group and large group, and then of course the self-insured that the market that the question was talking about. But this reinsurance program is really getting to your point of this unique aspect of that individual market being a relatively small pool. How do we appropriately balance that with state policies to make sure that it's affordable and stable? And what you're seeing play out at this national level is that they looked at Minnesota, which essentially served as a laboratory for state policy with our reinsurance program. We're now in our 5th year, and it might get adopted on a national level. It could be getting voted on right now. I haven't kept track of the news today. But it's really exciting to see that the prospect here get played out on a national level, and see that a policy that really started here in Minnesota was debated thoroughly and decided that it was a good policy for that very unique segment of the market. And kind of to your point, there's different powers at play, different pressures at play in the other aspects of the market.
Andrea, did you wanna say anything? You mentioned
I
we should.
I think that the Council of Health Plans and its members, we have long stood for wanting to make sure that everybody has access to affordable insurance. We recognize that the best pathway to being able to access care when you need it is to have good insurance. And so I think the efforts to support a Medicaid and Minnesota Care program in the state that provide access, along with the individual market reforms to ensure that people aren't stuck without coverage if you're not getting it through an employer group. I also think that Minnesota, from an employer group standpoint, we've done industry work together to ensure that the small group marketplace was set up in a way that would set ground rules for a strong and vibrant, fully insured, self-insured market. We're in a time of great transition right now as employers, big and small, consider whether or not they want to assume the insurance risk. And many small employers right now, pre-COVID at least, have chosen a self-insured route as a way to finance healthcare, and then turn back to the health plans to provide stop-loss coverage to protect against outlier claims. But I think that, not as nonprofit health plans, our commitment to being able to serve all and ensure financial stability for the full population has been a hallmark of the Council of Health Plans for some time.
Great.
I think in a broader sense too, Pinar, one of the things that we're all doing is working with the providers and focus more on value than fee for service. I think Andrea has the luxury of being an integrated organization, but the rest of us are working with the providers out there to try and have them take more risk, to understand how to help manage costs differently. And that was using the big data and focus on care plans and stuff to lower the overall cost of care. So there's a lot doing there. Obviously, prescription drugs and the pharmaceutical costs are something that has a higher trend than the regular cost of care. So we're all working with formularies and trying to work with our on the pharmacy spend. So that's across all segments though.
Yep. And actually, value-based care overall, yes, it resonates across all the sectors. And there's a question from the audience on value-based care. The question goes, we have been hearing about the shift to value-based care for many years now, but reimbursement is still largely on a fee-for-service basis, and the evidence regarding the success of various value-based initiatives has been mixed. Do the panelists believe that the shift to value will continue, and what opportunities do they see to pursue that in their organizations?
It will definitely continue, and it has to continue. It is not an option. I have the luxury of, we're in 11 states now, and we're only going into states where we're partnering with care systems that are committed to transformation. And to be honest with you, we are, very early on in the journey of transformation across this industry. There is so much more we need to do. But we are finding partners. I mean, Andrea is doing a lot in her organization to move to value. We're doing a lot with other partners across the state and across the region to really focus on using data and analytics to make sure people are getting the right care at the right time and really putting the providers at risk for their performance. And trust me, there are people out there that want to do this. They just don't know how. And it's really trying to transform the underlying fundamental economic model for the providers to give them a source of revenue to fund that transformation, because they've got, decades of this fee-for-service model. That's how they've gotten reimbursed, and they're trying to change it, but it is extremely difficult to do that. So Andrea, you want to add some stuff there?
Yeah, I would just add as an example, HealthPartners and Allina together formed a Northwest Alliance in the Northwest part of the Twin Cities. And that partnership was formed with a recognition that we needed to improve access to affordable care in that region. The medical trends in that region were outpacing the rest of the metro, and through partnership and a focus on value-based care, HealthPartners and Allina together were able to lower care costs and trends in that community and get to a place where people in that Anoka region had better access to mental health services, better access to a full continuum of care at a more affordable price. And I think that's just one of the examples, to John's point, about HealthPartners, health plans partnering with care delivery systems, our network partners, to improve things. The other thing I'd say about value-based care that's really important is Medicare. And the Medicare program focusing on value-based care and creating signal strength that reinforces the importance is really an imperative. And so the direct contracting programs that CMS is working on right now in Medicare, in concert with Medicare Advantage, with which all of the Minnesota nonprofit plans are participating in today, sets us up on a course that I think makes value-based care more likely to be a real thing as we move forward, and an increasing proportion of our work.
And really, again, from the research point of view, yes, the evidence is mixed, and I think we're still learning about the impact of these value-based programs, but there certain trends are coming up. Like, for example, organizations that have been doing these value-based care programs for a longer time period. So the experience with the program is definitely more successful in terms of cost reductions. Of course, the idea that the more accountability, those that put more risk in the two-sided models that put more risk, upward risk, as well as downward, are becoming more successful. Of course, there are a lot of challenges still as to how do you improve participation of the providers while making sure there is accountability. How do we define the benchmarks? And to me, really dear to my kind of work research is like, how do we define value? How do we measure it? Do we have the right metrics and the ability? And also really, I think like we need to think about how do we bring in the patient's perspective into these value definitions?
Yeah.
How can we measure from the patient directly and define that value?
Well, I will add that they are working when you have the right models. And again, we rolled out the first ACO on a commercial basis back in 2011, and the University of Minnesota was one of our first clients. But then they said, it's great you have it in the metro, but we want it at all campuses. So we built that network statewide. And so we have 10 years of data that shows Pinar that people that choose those products, because you choose it at enrollment and you create that one-on-one connection with your system, and they now know you, and you create a one-on-one relationship with your physician. So you're getting better engagement and activities. So preventive care is up, that population versus open access. Costs are down relative to an open population and a risk-adjusted basis. So there is data in the state that shows that these models can work if you've got both the provider and the plan working together, and in some cases with the employer, to drive better health and better outcomes.
Great. So I have one other big question. Actually, three
Sorry, we're out of
questions.
time.
3 questions that are sort of all around the same theme. Then I will again read the questions, but the theme is around the for-profit entry into Minnesota's nonprofit landscape. So I'm going to read the questions, and feel free to choose how you want to answer them. So one of the questions is about United Healthcare entered the market and subsequently acquired Preferred One from Fairview. How do your organizations view UHC's entry and shifting provider alliances? So that's sort of one. The second one is, again, kind of related. Going back to the payer landscape in Minnesota, how do you think the industry will change now that for-profit payers have a presence in Minnesota, and how will this change cost of care? And then the third one is more specific to the Medicaid program, but again, will we see any impact on the quality of care being provided due to the for-profit HMOs becoming a part of Minnesota's Medicaid program? So 3 big questions, all on that theme of now we have for-profit presence, and how does that impact costs and the Medicaid program and provider alliances, to summarize, I guess.
I'm happy to take a stab at this one.
We
I'll
have
jump
7
out.
minutes.
I'll jump out there. I think we welcome competition. I mean, competition keeps everybody on their toes and keeps it sharp. So regardless of for-profit or nonprofit, we need ideas, we need solutions to help improve the health of our community. So we welcome that. I think what we talked about earlier was the nonprofits in this community have decades of experience working collaboratively with the state, with the providers, and really making a difference in our community. If you look at some of the programs we rolled out, they were joint efforts between the plans, the providers, and the state. And we really have been a role model of innovation in Minnesota and trying different things. I don't know if that will change going forward with for-profits entering. I know we continue to invest our resources into our foundation, into our community, and into our neighbors. Not saying that they won't do that, but they have other stakeholders that want a piece of the pie as well. So welcome their entry. Andrea, go ahead.
Yeah, I was going to say, I think that's right. Competition in the marketplace is a good thing. We have had for-profit competitors in the marketplace before. So while HMO for-profit competitors are a new thing, we have for a long time had insurance, for-profit insurance carriers in this marketplace. That is the new element is the HMO license versus for-profits. The other thing I would say is tools like Minnesota Community Measurement that measure value both in terms of clinical outcomes and total cost of care are important. JD Power, NCQA, CMS, I mean, the organizations that do the third-party validation on the value that plans bring to the market will be how all of us will get measured. And so, we will need to do our level best and continue to perform and bring value to the community as we have in the past. The name of the game will be innovation and competition to produce better results.
Thank you. Lucas, did you want to add?
Sure, Pranav. Maybe I can just give some perspective around what we're talking about here. Is that United Healthcare is obviously an enormous national company, but here in Minnesota, they're relatively small, and a lot of people don't realize that. Combined, I think they have roughly around 500,000 enrollees in Minnesota. Well, just the two organizations on this panel here have millions, and collectively our members insure 4.5 million folks. So they're going to have a growing presence here, especially with this engagement in Medicaid that will start next year. And I think what you heard from both John and Andrea is that we're going to work collaboratively to make sure Minnesotans get that support that they need.
Great, thank you. So I have one last question that is sort of picking up on one of the questions here, but it's about going back to this idea about closing gaps in social care, especially with the social determinants of health needs of the communities that all of you have talked about, but creating more sustainable programs. So the question is, as community-based organization, we see interest from health plans in closing gaps in social care, but that interest rarely translates to meaningful resources to create and sustain programs that can drive health outcomes. Often the dollars health plans use come from marketing foundation or special initiative dollars that are very time limited and insufficient to the needs, particularly when considering your need to think about these efforts in the context of proof of effectiveness as measured through stars, claims, etc. How do we build social interventions, especially home and community-based services, into the medical loss ratios or premium so that your members and our neighbors can access these services? For example, health promotion programming, caregiving, care support services, homemaking, chore services outside of the MA and MSHO populations. And I think that's sort of our very last question.
Well, perhaps I can start, given that I think a lot of that frustration stems from the uncertainty of state and federal funding. But what you're seeing at the health plan level is really a sustained focus on what actually works and trying to keep it going. So I think we heard Andrea talk about that a little bit earlier, and I saw, John, you came off mute, so jump in if you're ready.
Yeah, I was just going to say, in your question itself was the answer. We do need to do those things, but we also have to be able to sell products that are affordable. And so there's that tough balance that we want to provide support initiatives. Andrea and I both listed a few earlier. We're working with, again, a lot of the providers on some of those initiatives. You said it, but at the end of the day, we are using our limited dollars. If you look at a dollar premium, 85 cents goes to pay for the cost of care, and then you got 15 for others. And as Andrea said, we've got to keep reserves adequate, et cetera. But we are all funding initiatives to try and do that. And again, I think we have a track record in the state of doing stuff together to make a difference.
I think using frameworks to measure value. I mean, we need new models, new business models to help support efforts. And I think we need to prove that there's higher value in those new business models. We've, through our research institute, actually come up with a way that we are evaluating the investment we're making in Little Moments Count, in Make It Okay, our mental health efforts. And as we co-design with community, we need to prove out, to John's point on affordability, that what we're able to produce is better health at a lower cost.
Thank you so much. And you saw me, I don't know if the audience can see, give thumbs up, because the idea around, different business models and innovation on business models when it comes to these topics is definitely something we at the Carlson School will want to partner with all of you as well. So really our doors of collaboration are all open, and we really, really look forward to it. We are out of time, but we do have a networking session. So I know that Kim Choi, who is the magic who makes these things happen, who's MILI's program administrator, I think she has left to the networking session. So please, everyone on the call, feel free to join us at the networking session. There's a Zoom link that you can see. We will keep this forum a little bit open until you can switch away too. But for now, I really, really want to thank so much to Andrea, John, and Lucas for your time, for meeting our community here, and for sharing your insights. Thank you so much.